Hi, my name is Justin Griffin. I'm a family nurse practitioner student at United States University. I'm going to be doing a focused examination today on the head, ears, eyes, nose, and throat. Can you tell us your name?
Katrina Griffin.
And do you consent to us doing this exam and putting it on YouTube?
Yes,
Do you consent to me touching you?
yes.
Okay. And we're going to begin. The first thing that we need to do with a head, ears, eyes, nose, and throat exam is inspect the head. So while you're looking at the head, you want to check for symmetry. You want to check for lacerations, cysts, any coarseness of the hair. You want to check the skin and make sure it's not pale or looks jaundice. After that, you would palpate um, the head. Palpate means touch, and make sure there's no hematomas, no uh, bumps or lesions or things that shouldn't be of the abnormal. See if the skin is dry. Looking all the way through, and again, looking all the way down. And everything looks good, and she has perfect symmetry. Her ears aren't going one side more than the other. Next, we're going to go ahead and go straight down to the nose. First thing we should do here is we should check the sinuses. You have the frontal and the maxillary. So you kind of, I'm sorry, first you have to inspect, make sure that there's no drainage, there's uh, um, no blood, the septum's not deviated to one side, no abnormalities going on. Again, no cysts or lesions, or it's not swollen, it's not hematoma, it doesn't have any crust down the end, it doesn't look irritated, those kinds of things. Then we go into palpation. So again, we'll palpate the sinuses. One is the frontal, second is the maxillary. When you push right here, did either of these hurt?
No.
No, so you know that her sinuses are okay. Um, Next, what we can do is we actually take our pen light and we're going to look up each side of the nostrils to make sure that her turbinates are okay and they're pale and blue. So looking up one side. I don't need to put it up too far. Good. Again on the other side. Good. And those look really good there. Next, we do the sniffed and airway test. So we have them sniff something that does not cause their salivary glands to act up. This is hair product, so we'll have to have her sniff on one side. Can you smell that?
Yes.
Get on the other side.
Yes.
Can you smell that? Good. Um, then after that, we'll have her do an airflow test. So you kind of have her push on one nostril, breathe in and out. Good. You can hear it go through. So this, and do it on the other side. Breathe in and out. Is everything okay?
Mm-hmm.
Good. From here, we're going to go right down into the mouth. So I like to keep everything when I inspect. I kind of go down, so we're going to see that you're going to go head, nose, mouth, neck and throat, ears, then eyes. That's just how I do it. It's a little different than most. So again, back to the mouth. When you look and you're inspecting again, you're looking to see if she has any dry lips or any crust or irritation or even any lesions, like herpes, so on and so forth. Next, you want her to open up her mouth. Open. I'm not touching you yet. You're checking out the buccal mucosa. You're looking on the side. You're looking at her teeth to see if she has any caries or missing teeth. Um, you're looking at her tongue to see if it's pale or big. Hers is not. Um, keep opening your mouth for me. Lift up your tongue. You're looking at the salivary gland, see if there's anything back. Again, you can use your light again and look in the back of her throat. Say ah. So that's checking the cranial nerve. And if we have a little drink of water here in a second, we'll do that. So again, open up. Her uvula is midline. You can't really see her tonsils too much, so that means it's grade 1, because if they're closer they get inwards and swollen, the higher the grade goes. and hers are clear. The back of her throat looks nice. And next, we really want to test her strength of her tongue. So what I'll do is, if you open up your mouth, and then push against it. Good. Push against the other side. Good. And she had good strength on both of those. So it's looking good. She did say ah earlier, and her uvula lifted up, and that's what we want. That's what we want to see. Next, she's gonna swallow here, and we'll see that everything's swallowed and went roll. So those are cranial nerves 9 and 10, and the tongue going out and going side to side is cranial nerves 12. From here, we're gonna move on. We'll go right to the kind of the neck. From the neck, we're gonna check out all of her lymph nodes. So she has 7 of them that we're gonna look at. So the first one's nice and gentle. We're gonna touch right here. These are her preocular, and then you have your posterior ocular, and then coming down to the front, you have your submental. Then going on to the side, you have your submandibular. And then in the back, you have your occipital. And then coming here, you have your anterior carotid. Anterior cervical, posterior cervical. And then you have your supraclavicle. Sorry, my patient's really ticklish, so she really doesn't like that. Again, you were supposed to inspect beforehand. Sorry, Dr. Earl, don't raise your eyes. And then we want to check for her trachea, make sure it's midline, it's not going from one side to the other. And for hers, it's straight. From here again, when you inspect and you don't see any goiters, any erythema, any irritation, maybe some dry skin or something that's a little not normal. In this case, she doesn't have anything. Everything's symmetrical and looking good. One of the last things we're going to do is we're going to look for her thyroid gland. To find that, you actually should stand behind the patient. So you're supposed to look at it first to make sure it's not there. And I don't see it. And we looked at it earlier when she swallowed. All those were expecting there. When you come behind her, can you turn all the way to the camera? Good. You really want to look for. You want to come behind. You want to explain to her that I'm going to put my hands around you. You don't want to just go and kind of almost act like you're choking her. You're going to let her know you're going to come behind and touch gently. Lift your neck up, please. And then when you come in here, you're looking for the cricoid cartilage. I'm going to back up. We're looking for the cricoid cartilage, and that's usually a little bit below the Adam's apple in men. With her, obviously she doesn't have an Adam's apple. But so we're going to touch here. And she's sorry, she can't stop laughing. This is making me laugh. Well, as I'm doing this, it's you go to the cricoid and then you move out to the side. When you move out to the side, you have the patient swallow. So if you'll get some water over here or over there, you have the patient swallow, and then you can you can feel it move. Did you swallow? There you go. Okay, and you swallow. And now that I'm already here, I like doing it afterwards, but then you can have the patient pull their shoulders up and down. Shrug your shoulders. This tests for cranial nerve 11. Good. That's good. Coming back down. All right, now what we're going to do is we're going to go right into the ears. So I told you we're going to go straight midline. So we're going from head to nose to mouth to neck. Actually, we have to go back to the neck. I forgot a big portion. We have to do range of motion. So first I need her to flex. So I want her to go down. I want her to come up. Good. I want her to go lateral left. Right. Then I want her to, rotate like we did. Yes, left to side. And then I want her to rotate. And then what you need to do is you need to make sure that she has good strength. So you can put your hand on each side. So go ahead and push against me. Good. Then we come back to this side. Go ahead and push. Good. And that's good strength. So she has +5 strength-wise. That's good. Now we can move on. So next we're going to move on to the ears. So the first thing that we need to do, like we do always, is inspection. So looking at the ears, you really want to check everything outside, like the pinna, the top of the ear, the tragus. Make sure everything looks good, one on each side. They look good. Are the ears bent back? Are they smaller? Are they misplaced? Those are all abnormal findings, and we don't have that. Is it red on the outside? Does she say it's painful? Those are all parts of inspection. After that, we're going to do palpation. With her, you actually want to touch the pinna or the tragus first. Once you touch the pinna, you want to ask her, is there any pain?
No.
No. Touch the trachea, is there any pain?
No.
No. The reason we do that is because if she has like otitis externa, it'll be very, very painful, and you know not to continue, or advise her that, you know, we're going to continue even though it's a little painful. Next thing you want to do is you want to make sure you hold your otoscope, in a way that's safe for the patient. So you kind of pull this up, turn the light on, but make sure that you touch her with your hands before you're going in to look. That makes sure if someone bumps in the back of you, you're not shoving the otoscope into the ear. You have complete control. So as I look on the outside of the ear first and touch, so you want to pull up and back. When you pull up and back, looking at the exterior canal of the ear, I don't see, it's not red, it's not irritable, there's no draining. It looks good. Now when I go up and in, sorry, it's so painful. You can see her tympanic membrane, and the cone of light. The tympanic membrane is not red, it's not inflamed, it's not bulging. The cone of light, because this is on her right ear, is at 5. And then we got to do the same thing. She'll turn a little bit towards me, and we got to do the same with the other side. Again, touching the pinna first and touching the tragus. Good. And then we're going to go in here. Look in. And again, we see the cone of light on the left side at 7. Her tympanic membrane is gray. It's not red. It's not bulging. And then from here, we have 3 special tests that we have to do. The first test is is it really a hearing test? It's the gross hearing test. The gross hearing test is when you have the patient, you're supposed to stand behind them, but you have the patient cover one ear. So go ahead and cover one ear, and you're going to say a 2-syllable word. And if they can hear it, that's good. If they can't hear it, we got to dig in a little deeper, because that's an abnormality. So in this case, we'll say like apple and baseball for one side. So I say
Apple.
good.
Baseball.
Good. So this is, as you can tell, this is called the whisper test. Put it on the cover of the other ear. Do the same thing. Say
Apple. Baseball.
good. And she could hear both of them. From here, we'll have her turn back. We're going to do what's called the Weber test. And the Weber test, this is a tuning fork. You want to tap the tuning fork with your elbow, and you want to put it right in the middle of her forehead. She'll feel the vibrations and hear the sound. Should be bilateral on each side. If it's more on one side than the other, we know it's an abnormality. Can you feel that?
Mm-hmm.
Good. And then normally you wait until she can't feel it anymore. But for the purpose of this test, we're gonna move on. Then the last test is the Rhines test. The Rhines test checks conductive hearing, and it's also neurosensory hearing. So conductive hearing is when there's bone in the back here. If there's an extra bone or something on the inside, it'll impair her hearing. And with the neurosensory, what we're going to do is this is going to go in the back and touch here, and then when you can stop hearing that vibration, you pull it off the back of the ear and in front of the ear, and she should be able to hear it still, even after the back. That's the neurosensory. If she can't hear it here, we need to start thinking it's a nerve damage. So here we go. And you want to do this on each side. Feel that? Good. And we're going to pretend like it's getting to the point. Can you feel it here?
Yes.
And you want to do it to the same thing on the other side. And bring it behind here. Can you hear that?
Mm-hmm.
And again, bring it to the front. And again, you're supposed to wait until she can't hear it anymore, but she's kind of sensitive, so we're gonna keep going. All right. Next, what we need to do is we're going to look and inspect the eyes, but let me quickly change my otoscope to my ophthalmoscope. I know, I'm sorry. And when we do this, you want to make sure it's at 0, but we'll get to that in a second. So first, again, it's inspection. You want to look at the eyes. You want to see if there's any irritation, any bumps or lesions or cuts, or is it swollen? Does her scleras look a different color, such as a yellow, jaundice? You want to look at the irises, the pupils, and the cornea. Make sure everything's okay. You also want to kind of look down under conjunctiva. Good. You want to take a light and kind of turn that way. You want to take the light and kind of look on the side of the eyes. Make sure there's, again, no drainage, and you're looking for the lacrimal system to make sure there's nothing going on. Next thing we're going to do is we are going to go into doing kind of light tests. So with this, you actually want to shine a light right into the patient's eyes. And what you're going to do with it is you're going to make sure that the pupil constricts. That's called direct constriction. And then if you do it once, the left eye itself should constrict. If you do it twice, the right eye should do it, and that's consensual. And you want to do it on each side. So the first one, and looking at here, looking at the eye, good. And then looking back, good. And she does have consensual and direct on the left eye. And again, we'll do it again on the right eye, here, come down, come back up. Good. So those worked perfectly. Next, we're going to check the 3 cranial nerves, which are nerves 3, 4, and 6. They are called the ocular motor, the trochanter, and the adducens. So how to do that is you have the patient first kind of follow your finger. You gotta keep turning this way. I'm gonna work with you, but they gotta be able to see it. So you kind of want to start with your finger here, and you want to move it in almost like an H pattern, making sure that her eyes move with you, and one's not being left behind. One stays with you. In here, going back up, going back down, and you're checking also for some nystagmus, which is like a shaking of the eye. She doesn't have that. Next, you're going to look for accommodation. Accommodation is when your pupils constrict and then dilate when they look away. So you have her say, look at my finger, and then look at something far behind me, and then back to my finger. And you'll notice that the pupils in accommodation constrict. Now the convergence is when I say, look at my finger and watch it come to your nose. When you watch it come in, her eyes themselves will both close up. That's convergence. That's what we want. Next, before we blind her with too much more stuff, we'll do the Snellen chart. And you're supposed to stand 20 feet away with this. You have the patient open both her eyes and look at this, then cover one eye, then cover the opposite eye. For this, I can't really stand 20 feet away, but what you would tell her is you would say, read the bottom line or the line that you can read the best, which is which one? This one? The bottom one here. Okay, what's the bottom one?
L T F P H.
Good. Then you would have her cover one eye and read the bottom.
L T F P H.
Good. And then we switch to the other eye. And then what I like to do is I like to say, okay, now try to do it backwards so they're not memorizing the chart on you.
H P F T L.
Good. And that shows that she has 20/20 vision, which is good, perfect vision. Next, we're going to use our ophthalmoscope, and we are actually going to check for her red reflux. Again, make sure that you have safety with this, and you want to make sure that if you are checking out her right eye, that you are using your right hand. This is kind of difficult for me because I have glasses. I don't particularly like it, but so I go here. I shine the light in her eye. Turn it on. 1, 2, 3. And then I look for her red reflux. I see it with her, and if there's an absence of a red reflux, you're looking for a retinoblastoma, which she doesn't have. Then you find that one spot. You go in really close, good, and you're looking at the optic disc. And with the optic disc, you also have the optic cup, and you want to make sure that her that it's a 1-to-2 ratio, meaning that it's a little bit, the disc is a little bit smaller than the cup. You also want to check for the vessels, and the vessels in there are not bursting or they don't have any redness or anything like that. You don't want to do this for too long because it's obviously irritating to them. So we check for while we're in there, we also check for the cornea and the lens and make sure that there was no abrasions or problems. But we're going to do the same exact thing to the other eye. So again, we switch hands because you want to do the left side with the left side. You keep your thing, your fingers out so that you protect her. Turning it on here, and then you find that red reflux. Good, and then we go all the way in. Good, and then again, there's the optic disc, and you see the vessels, and the optic disc again is not of a different size. I mean, it's a 1-to-2 ratio. It's not hurting her. There's no pain with it. The cup size is the same as the other one. And then her vessels on that side also are not hurting her, or are not. They don't look swollen. They don't look red. It's inside. It's orangey, pink, and not irritated or red or anything like that. I think that does it. That'll be the full head, ears, nose, and throat exam. Thank you for watching.